Imagine, imagine surviving breast cancer. Like you finally get to ring that bell in the oncology ward and you go home thinking, the absolute worst of the battle is finally behind you.
Right, yeah, the survival part is done.
Exactly. But then, a few months later, you realize that the daily pill you have to take to keep you alive is causing so much localized physical agony that you'd honestly rather risk the cancer coming back than take another dose.
Which is just a horrific choice to have to make.
It really is. And for nearly 1 in 5 breast cancer survivors on certain medications, that agonizing choice is literally their daily reality. So today we're taking a deep dive into a fascinating and honestly kind of controversial non-hormonal treatment that is trying to fix exactly that.
Yeah, and it's a devastating reality. I mean, it fundamentally changes how we even think about survivorship, The prevailing narrative in medicine is often just like, kill the disease, cure the patient.
Right, just get the cancer out.
Exactly. But when the cost of that cure completely dismantles your day-to-day quality of life, the medical community really has to figure out what comes next.
Which brings us to the core mission of this deep dive. We are tackling a very specific, really high-stakes clinical question today, and that is, can the O-shot, which is autologous platelet-rich plasma therapy, can it be safely administered to breast cancer survivors who are currently taking active endocrine suppression therapies?
Specifically, we're looking at patients taking aromatase inhibitors, so drugs like anastrozole, letrozole, or exemestane.
Yeah, the big ones. And to get to the bottom of this, we're looking at a pretty hefty stack of clinical literature today.
We really are. We've got a phase 1 prospective study from the Mayo Clinic. We're also looking at the upcoming phase 2 clinical trial parameters out of the University of Miami, along with current oncology guidelines and some peer-reviewed case series from places like the Indian Journal of Obstetrics and Gynecology Research.
It's a lot of data. But we're pulling all this together because for you listening right now, like whether you're a survivor yourself or maybe a clinician trying to navigate these incredibly tough conversations with your patients, or honestly, just someone fascinated by the frontiers of women's health, this topic sits at such a vital intersection.
It really bridges oncology, gynecology, and regenerative medicine, all to kind of redefine what a cure actually looks like.
Yeah, because surviving shouldn't mean just, accepting a permanent state of suffering.
Absolutely not.
So let's start with the root of that suffering, because before we can even evaluate platelet-rich plasma, we have to understand the biological corner that these patients are backed into, right?
Yeah, you have to understand the mechanism.
Right. So we're dealing with estrogen-sensitive breast cancers, which I think account for about 75% of all breast cancer cases. And the cancer cells essentially hijack estrogen, using it as fuel to, divide and conquer.
Exactly. So once a surgeon removes the primary tumor, the ongoing strategy is to just aggressively starve the body of that fuel.
Starve the cancer, basically.
Right. And that starvation tactic is where aromatase inhibitors, or AIs, come into play. So in postmenopausal women, the ovaries aren't really producing much estrogen anymore anyway.
Right. They've kind of shut down.
Yeah. Instead, their bodies produce androgens, which are male hormones, and those travel through the bloodstream into peripheral fatty tissue. And there, this enzyme called aromatase essentially grabs those androgens and converts them into estrogen.
Okay, let's unpack this for a second. So the aromatase enzyme is basically the manufacturing plant for estrogen in the postmenopausal body.
That's a great way to put it, yeah. And the drugs we're talking about, like letrozole or anastrozole, they bind directly to that aromatase enzyme. They act like a giant padlock on the factory door.
Oh, wow, okay.
So the androgens can't get in, the conversion can't happen, and estrogen production just plummets to virtually zero, which is highly effective at stopping dormant cancer cells from waking up.
So it's less like pulling a weed from a garden and much more like shutting off the main water valve to your house to stop a catastrophic leak. Like, yes, you stop the flood, which is the cancer, which saves the house. But the unintended consequence is that now the garden outside is completely drying up and dying because it doesn't have any water.
That is a perfect analogy. And in this clinical context, that garden drying up is the profound degradation of the vaginal and vulvar tissue. Clinically, this is called genitourinary syndrome of menopause, or GSM.
Which used to be called, what, vulvovaginal atrophy, right?
Historically, that was the term.
And looking at the data in our sources, the prevalence of this is just shocking. Up to 70% of breast cancer survivors on these therapies develop GSM.
It's a massive number.
It is. And we aren't just talking about mild discomfort here. The sources describe severe vaginal dryness, burning, and tissue fragility that is so extreme that the mucosal lining can literally tear and bleed just from light contact, or even just walking.
Right, the friction alone causes micro tears.
It causes severe dyspareunia, so painful sex, and these recurrent, just incredibly stubborn urinary tract infections.
Yeah, and if you think about the mechanics of the tissue, it makes sense. Estrogen doesn't just provide lubrication. It is literally the architect of that local environment.
How so?
Well, estrogen maintains the thick layers of the epithelium. It stimulates fibroblasts to pump out collagen and elastin. It keeps the blood vessels robust. And furthermore, it regulates the local microbiome. Like it feeds the good bacteria, the lactobacilli, which keep the vaginal pH slightly acidic.
Oh, wow. So when you padlock that estrogen factory with the AIs, the whole architecture just collapses.
Exactly. The tissue thins out, it loses all its stretch, the blood vessels retreat, and the pH shoots up, which creates this perfect breeding ground for bad bacteria.
Which totally explains the recurrent UTIs.
Precisely. It is a total systemic breakdown of that localized environment. And the stakes go way beyond just a compromised sex life, you know? As we touched on earlier, the pain becomes so overwhelming that nearly 20% of women on AI simply stop taking their medication.
They quit the chemotherapy.
Yeah.
I mean, that is the detail that absolutely floored me.
It's hard to believe until you hear the patient's stories.
Right. Because when you're sitting in a doctor's office, the choice seems obvious, right? Take the pill, don't get cancer.
Yeah.
But living with that choice day after day, year after year, when literally every movement hurts, I mean, it pushes 1 in 5 women to abandon the very treatment keeping them alive. That is a massive crisis in oncology compliance.
It really is. And it begs a really frustrating question for patients. Like, if the issue is a lack of estrogen in the vagina, and they already make topical estrogen creams for women going through natural menopause,
Right.
why can't breast cancer survivors just use a localized cream to fix the tissue?
It seems like the most obvious loophole, like you're just applying it to the local tissue, you aren't swallowing a pill, so maybe it doesn't affect the whole body. But our sources are very clear that this is a really dangerous trap.
Oh, heavily dangerous.
Yeah. Vaginal estradiol and even DHEA, which is like a precursor hormone, they are heavily cautioned against or completely contraindicated for survivors on aromatase inhibitors.
Yeah, because the entire goal of an aromatase inhibitor is to keep systemic estrogen levels totally undetectable. Even when you apply a cream locally to the vaginal mucosa, a fraction of those exogenous hormones will inevitably absorb into the bloodstream.
And since breast cancer cells are incredibly sensitive, even a microscopic spike in systemic estrogen could theoretically act as like a flare gun.
Exactly, signaling any dormant cancer cells to wake up and start dividing again.
Right. So introducing even a tiny amount of hormone counteracts the entire purpose of the endocrine therapy. So for decades, the medical community essentially just threw their hands up. They told these women, well, you can survive your cancer, or you can have a functioning, pain-free pelvic floor. You cannot have both.
It's a terrible ultimatum.
But if synthetic estrogen is effectively poison for this specific patient population, we have to look entirely outside the endocrine system for a solution. Like, we need a way to repair the architecture of the tissue, the collagen, the blood vessels, without using any hormones.
Which is where platelet-rich plasma, specifically the O-shot, enters the clinical picture.
It's such a fascinating pivot from endocrinology to regenerative biology.
It really is.
Now, I do want to push back on this for a second, because I think a lot of people listening will have the exact same initial reaction I did. When I hear O-shot, my brain immediately goes to, like, expensive med spas and influencers posting about cosmetic wellness on Instagram.
Yeah, for sure.
It sounds like a trendy luxury procedure. So how does something with that kind of branding fit into serious life and death oncologic care?
I completely understand the skepticism. I mean, the branding leans very heavily into cosmetic enhancement, which absolutely makes it sound frivolous. But if we strip away the marketing term, the O-shot, and look at the underlying science, what we are actually talking about is the precise, localized injection of autologous platelet-rich plasma, or PRP.
Okay, and autologous meaning the materials are harvested directly from the patient's own body, so no synthetic drugs, no animal-derived hormones.
Exactly. It leverages the patient's own cellular machinery to trigger tissue repair. Let's break down the actual physics and protocol of how this works, because it's not magic, you know? It's literally fluid dynamics.
Okay, let's hear it.
The procedure starts with a standard blood draw from the patient's arm, typically about 34 milliliters of whole blood.
Which is just about the amount they'd take for a couple of standard lab tests, right?
Right, it's a very normal amount. That blood goes into specialized tubes that contain an anticoagulant so it doesn't clot. And then it goes into a centrifuge for a very specific double spin process.
And the speeds of those spins are critical, aren't they? Like, if you spin it too fast, you risk shattering the platelets due to the G-force.
Right.
But if you spin it too slow, you don't fully separate the heavier red blood cells from the plasma.
Yeah, the physics have to be exact. So during that first softer spin, the machine separates the heavy red blood cells at the bottom from the lighter plasma at the top. But right in the middle, there's this thin, cloudy layer called the buffy coat.
The buffy coat.
Yeah, and this is where the platelets and the white blood cells, like macrophages, are suspended.
So the clinician extracts that buffy coat and the plasma and leaves the red blood cells behind. Then what happens?
Then they run a second, much faster, harder spin on just that extracted fluid. This forces all those platelets to condense into a dense pellet at the very bottom of the tube. The clinician removes the excess platelet-poor plasma from the top and resuspends that dense pellet into the remaining lower third of the plasma.
Okay, wow.
Yeah, and what you're left with is about 5 milliliters of highly concentrated, basically liquid gold PRP.
So you've taken 34 milliliters of whole blood and distilled it down into just 5 milliliters, where the platelet concentration is, what, 6 to 7 times higher than normal.
Exactly.
The clinician then applies a strong topical numbing cream to the patient and uses a very fine needle to inject this PRP directly into the anterior vaginal wall near the urethra and the posterior vaginal wall. But, let's connect the dots here. We've got concentrated platelets in the tissue. How does that actually rebuild the broken down architecture without using estrogen?
What's fascinating here is understanding the how. Think about the last time you had a bad paper cut or scraped your knee.
Okay.
Your body's immediate first responders are platelets. They rush to the site of injury, and they don't just stop the bleeding. When platelets activate, their cell membranes essentially open up and dump a massive payload of growth factors into the surrounding tissue.
Ah, okay. And these growth factors act like chemical homing beacons, right?
Exactly. They signal local stem cells and structural cells to wake up and get to work. So when we artificially concentrate millions of platelets and inject them into the vaginal mucosa, we are essentially tricking the body into thinking there has been a massive trauma that urgently needs repairing.
That is so clever. So you're inducing a healing cascade on demand.
Yes.
And I know the sources highlight a few specific mechanisms here, like the growth factors trigger angiogenesis, which is the formation of brand new capillary blood vessels, restoring blood flow to that starved tissue. And they also activate fibroblasts.
Right, which are crucial.
Yeah. If we remember our biology, fibroblasts are the cellular factories that manufacture fresh collagen and elastin.
You are literally rebuilding the tissue from the ground up. You are growing new vessels, creating new elastic fibers, and thickening the mucosa entirely through cellular regeneration. It completely bypasses the estrogen receptors.
Because there's no estrogen involved.
Exactly. The tissue isn't healing because it's being fed hormones. It's healing because its own internal repair kits were deployed in massive numbers.
Okay. I mean, the biological theory is brilliant. It makes perfect logical sense. But theory doesn't treat patients, right?
Mm-hmm.
If I'm looking at these sources, I want to know what happens when we take this theoretical mechanism and apply it to actual breast cancer survivors. What does the clinical data actually show?
Well, this is where we look at the Phase 1 prospective study conducted at the Mayo Clinic in Florida. It was led by Dr. Anita Chen. They specifically recruited 20 breast cancer survivors, ranging from stage 0 to stage 3, who were suffering from documented genitourinary syndrome of menopause.
And importantly, this included women actively taking aromatase inhibitors.
Yes, very important.
Now, it's a small sample size, obviously, which is pretty typical for a Phase 1 safety and feasibility trial.
Mm-hmm.
But the patient population is that exact high-risk group we're talking about. The average age was around 53. They were dealing with severe dryness and dyspareunia, and they went through the exact PRP injection protocol we just described.
Right.
So what were the measurable outcomes?
The efficacy data was pretty profound. The primary metric they used was the Vaginal Health Index, or VHI.
Okay.
This is a clinical tool that scores the tissue based on 5 parameters: elasticity, fluid volume, pH, epithelial integrity, and moisture. A score under 15 indicates severe vaginal atrophy. At the start of the study, the baseline mean VHI for these 20 women was 9.95.
Oh, wow. So extremely degraded, super fragile tissue.
Right, very poor health. But by the 6-month follow-up after the PRP treatments, that mean VHI score had more than doubled. It jumped up to 20.55.
That's incredible. The tissue literally transformed from severely atrophied back to a healthy clinical baseline.
Yeah, in just 6 months.
And what's wild is that it wasn't just a microscopic change either. The sources note that 90% of the women experienced a physical, measurable increase in their vaginal caliber, which they tracked using standard dilator sizes. The tissue actually regained its physical stretching capacity.
Which directly correlates to the subjective patient reports, too. On the Patient Global Impression of Improvement scale, the PGII, 95% of the patients reported that their symptoms were noticeably better.
95%.
Yeah, and half of them said they were much better, and a quarter said very much better. They saw significant, sustained improvements on the urogenital distress index as well.
That's amazing. But, if I'm an oncologist reading this, efficacy is only half the equation, right?
Oh, absolutely.
Because the entire reason we are having this conversation is because traditional treatments risk feeding the cancer. Here's where it gets really interesting. If we're injecting a massive payload of growth factors, which literally tells cells to divide and multiply, aren't we risking waking up dormant cancer cells just like estrogen would? What is the safety data here?
It's honestly the most critical question you can ask, because angiogenesis and cellular proliferation are exactly what tumors use to grow. However, the data strongly support safety.
Okay, good.
In a Browner Foundational study that analyzed 163 sentinel lymph node biopsies, and they followed them over 30 months, PRP injections were deemed, quote, oncologically benign.
Okay, meaning the growth factors stayed local and they didn't systematize or encourage tumor growth.
Correct. There were 0 cases of cancer recurrence or death associated with the PRP treatment in that data set. And when we look back at the Mayo Clinic trial specifically, 0 patients experienced a breast cancer recurrence during the study period.
Wow. But wait, let me make sure I'm emphasizing the most important statistic in that entire Mayo Clinic paper, because to me, this is the detail that shifts the whole paradigm.
Yeah.
During the trial, out of the 20 women treated with the O shot, 0 patients stopped taking their aromatase inhibitors.
None. 100% compliance.
If you connect this to the bigger picture and compare that to the 20% dropout rate we discussed at the top of the deep dive, the implications are staggering. By effectively treating the agonizing side effects of the aromatase inhibitors, the O-shot isn't just making sex more comfortable. It is actively keeping women on the drugs that prevent their cancer from coming back.
Exactly. It stops being a cosmetic wellness perk and it becomes an essential compliance tool. It treats the side effects so the patient can actually tolerate the cure.
That is a phenomenal breakthrough. But we have to keep our feet on the ground. As fascinating as this is, it's our job to maintain scientific rigor here. No medical procedure is a flawless, magical cure-all. And if you're listening to this and considering your options, you need the reality check. So let's talk caveats, limitations, and side effects. First off, we're talking about needles in a highly, highly sensitive area.
Yes, and we really shouldn't sugarcoat that. While there's no surgical downtime, it isn't painless.
Right.
Despite the strong topical numbing cream, patients in the Mayo Clinic study reported a mean pain score of 3.9 out of 10 during the injection itself.
Yeah, 4 out of 10 is definitely something you have to grit your teeth through.
It is. Patients also reported mild temporary side effects post-procedure, things like spotting, a burning sensation, some cramping, and local irritation. The silver lining, though, is that these were easily managed with standard over-the-counter pain relievers like ibuprofen, and they almost universally resolved completely within 24 hours. Plus, there were no systemic allergic reactions, which makes total sense since it's the patient's own blood.
Right. You're not going to be allergic to yourself.
Yeah.
Our sources are also very explicit about managing expectations regarding what the O-shot can actually accomplish. For instance, they emphasize that it is not a libido pill.
That is a crucial distinction. Human sexuality and arousal are incredibly complex. They rely heavily on the central nervous system, psychological well-being, emotional state.
Yeah, it's not just physical.
Exactly. The O-shot strictly works on the peripheral tissue. It rebuilds the local architecture so that physical friction doesn't cause bleeding, and natural transudation lubrication can actually occur.
So it says a comfortable stage, but it doesn't write the script. Like if a woman's libido is severely suppressed because she's exhausted from chemotherapy, or she's experiencing clinical depression, or severe body image trauma post-mastectomy, injecting platelets into the vaginal wall isn't going to just artificially flip a switch in the brain's arousal pathways.
Right. It removes the physical pain barrier, but it doesn't manufacture desire. The sources also note it will not fix severe structural failures, like advanced pelvic organ prolapse. That requires surgical intervention. Regenerative biology has its limits.
And that kind of leads to the biggest limitation of all right now, which is the state of the clinical landscape itself. The sources suggest that PRP in gynecology right now is a bit of the Wild West.
It absolutely is. And this is the main reason it isn't yet the universal standard of care. There is a severe lack of a standardized protocol across the industry.
Explain that for us. Like if I go to Clinic A and Clinic B, I'm not getting the exact same treatment.
You likely aren't. Because PRP is a biological product that's processed on-site, the variables are basically endless. Clinic A might draw 20 milliliters of blood into a certain brand of tube and spin it at 1,500 RPMs for 5 minutes.
Okay.
But then Clinic B might draw 40 milliliters, use a totally different anticoagulant, and spin it at 3,000 RPMs for 10 minutes. They might even use different methods to activate the platelets before injection.
So the recipe isn't standardized at all. And in scientific research, without a strict reproducible recipe, widespread transferability is basically impossible. You can't compare the efficacy of a study in Florida to a study in London if they're physically injecting wildly different concentrations of platelets.
Precisely. Without standardization, you can't scale the data to prove definitively to the broader oncology community that this works every single time, for every single patient. This is exactly why the field desperately needs larger, highly controlled trials to establish that gold standard recipe.
Which highlights the importance of the upcoming clinical trial at the University of Miami that we found in the source stack. They are launching a phase 2 trial, actively targeting 18 breast cancer patients who have a vaginal health index strictly under 15. Moving from phase 1 feasibility trials to strict phase 2 efficacy trials is really the only way to cut through that Wild West and lock down a protocol that every oncologist can trust.
Yeah, these trials are the necessary stepping stones. They take the isolated success stories and turn them into peer-reviewed, undeniable medical doctrine.
Well, we started this deep dive looking at a horrific catch-22.
Yeah.
Women surviving cancer only to find themselves trapped in a post-treatment landscape where the very drugs keeping them alive were destroying their tissue, with traditional hormonal remedies completely off the table.
It really forced them into a daily, agonizing choice between survival and suffering.
But based on the clinical trials and the biology we've explored today, it appears there is a scientifically sound lifeline. For breast cancer survivors on active endocrine suppression therapy, autologous platelet-rich plasma, the O-shot, it offers a safe, non-hormonal path forward. By leveraging the body's own natural first responders, it restores tissue architecture, increases elasticity, and drastically reduces pain.
And all without introducing a single drop of risky estrogen. It offers a biological mechanism to rebuild the house without ever turning the furnace back on.
So what does this all mean? For you listening, whether you're navigating this journey yourself or maybe supporting someone who is, the most important takeaway is this. You no longer have to accept suffering and silence as the inevitable, unchangeable tax for surviving cancer. The science is evolving. Regenerative medicine is proving that we can address these systemic problems locally and effectively.
Which leaves us with one final kind of paradigm-shifting question to consider. Because of its origins and its med spa branding, the O-shot is almost universally categorized by insurance companies as an elective, out-of-pocket sexual wellness procedure. It is very expensive, and it is rarely covered.
Yeah, it's viewed on paper as a luxury.
But if we look objectively at the data, if a treatment is proven to prevent 20% of women from abandoning the chemotherapy and endocrine drugs that stop their cancer from recurring, shouldn't the medical and insurance communities change how they classify it? Like, if it keeps women compliant with life-saving drugs, it's not a spa treatment.
That is the perfect provocative thought to leave you with today. When will the system stop writing this off as an elective luxury and start recognizing it as an essential, fully covered component of comprehensive oncologic survivorship care? If the ultimate goal is to cure the patient, we have to treat the whole patient. You can't just put out the fire and abandon the house. You have to help them rebuild. Keep asking the hard questions, keep examining the data, and we'll catch you on the next deep dive.